But first, something a little scary.
Yeah, deadly fungus. This is really interesting. So the CDC data shows cases of a concerning fungal infection are on the rise in Illinois, and the doctor is going to have to pronounce this for us, okay? Dr. Jatin Vyas, I hope I'm saying it right, is a fungal expert. Did I get your name right, doctor? If not, please correct me, and make sure you turn down your volume a little bit too, because it's going to reverberate back.
It's on.
Are you able to turn the sound down a little bit?
That's my correct.
Oh, you know what? It might be our producer there. There we go. We can hear you now.
You said I got your name right?
You certainly did.
Wow, well, the Monday isn't starting off so bad. Well,
and I like your background. It's beautiful.
It is beautiful. Thank you for being with us. Let's talk about this fungus. First of all, pronounce it for us, and then what do people out there need to know about it?
Sure. The fungus that you're talking about is Candida auris. Candida auris is a specific organism found in the Candida species. It's a yeast organism, and it can cause human disease and significant human disease. Fungal infections, most people will think about fungal infections. When I talk about it, they'll say, oh, I had a toe infection or a superficial skin infection. Some people will remember having vaginal infections, but these are infections that actually are invasive. They go into the body and then they cause significant disease. Candida auris is a relative newcomer on the market for organisms that cause these types of diseases, and they really target the most vulnerable patients that we have in our population. So those that are typically hospitalized or in like nursing facilities, and folks that engage medical care in a significant way, like our dialysis patients.
So how prevalent is this? Is it happening a lot? We're seeing there's a lot of cases here in Illinois and Chicagoland.
So the increase in the number of cases probably comes up from a couple different ways. Number one is that we are getting better at detecting it. Historically, we weren't as good at detecting this organism because it kind of came onto the scene now only about 10 to 15 years ago. And so we're now have better tools to be able to detect it. And I suspect that by detecting it, we're seeing more of those cases. The other part is that this organism is actually difficult to get rid of in the environment. So you can imagine a hospital room or a patient room. These things require a lot of decontamination above and beyond what we normally use to try to do the decontamination. And again, those protocols have had to be changed so that we can have those the organism get removed out of our environment. And so as a result of that, we're still seeing more and more of these cases. The third part about this is that these organisms have become more resistant to our typical antibiotics or antifungals, and as a result of that, it has the opportunity to stick around for a lot longer and therefore cause more disease.
Well, doctor, I want to ask you, because of that last statement about it kind of sticking around longer, what is the treatment, and then how does this spread from person to person?
Yeah, so the treatment for someone who develops a systemic infection oftentimes requires intravenous medications, and for those patients, they might receive a significant amount of medication, i.e. days or weeks. Whenever we isolate this out of a person, what we do is try to identify which are the best antifungals to use, and in some situations with Candida auris, we might find out that we're really using third or fourth line because of the level of resistance that has actually occurred in these organisms. And for those of us who are infectious disease physicians, when organisms start to gain this type of resistance to many of our first and second and sometimes third line agents, we get nervous about it because we're starting to use agents that oftentimes are not as good and have more toxicity associated with it. And so the spread is oftentimes, as you asked, is really about kind of a contact spread. So what ends up happening is it moves from oftentimes inanimate surfaces where it can live for many, many hours, and then it'll end up in our patients. It'll end up on their skin. It'll end up in close to their IV catheters. It'll end up in areas that have open wounds, and those are what we think are the likely portals by which this organism causes infection in those patients.
So does this show up as a rash at first? Like, how do you even know that someone actually has it?
Yeah, so these invasive infections don't typically start with a rash. They start really with signs and symptoms of what you would think of as a severe infection. So fevers, sometimes in patients they can become confused because of low blood pressure. They can develop other signs and symptoms of serious infections, oftentimes needing medications to keep their blood pressure up. And so when we see patients who have these types of symptoms, we're oftentimes drawing blood to try to determine what is the cause of that type of infection. In some people who may have chronic indwelling lines, those are typically patients who may be undergoing, let's say, dialysis, or some patients who have what's called a PICC line, or peripherally inserted central catheter. There may be some outward signs of contamination, but more often than not, we don't actually see the portal of entry, and it's only the signs of fevers and chills and just malaise that are the first harbingers of this invasive infection.
Well, you know, doctor, I feel like it's probably not spotted right away, you know, because people might think, okay, well, if you have a fever, you have the chills, maybe you have the flu or another kind of infection. So are they testing for this right away as one of the first tests that they're administering, or how long does it usually take for them to find out or, you know, think to test for this Candida?
You're right. The symptoms that I just described are often fairly nonspecific. Someone who has a bad cold or who could be having flu. We're now in flu season, so the symptoms overlap significantly with that. And so what we're oftentimes looking at is what type of patient population are we looking at? If this is someone who's young and otherwise healthy, not on any immune modulating agents, or whose immune system, as far as we know, is relatively normal, we don't think of Candida auris as one of the first things that we want to test for. We're more looking for the common things. So that's oftentimes around this time of the year will be influenza and other respiratory infections like COVID-19. For other specific patient populations, if you're a recipient of a bone marrow transplant, you have an organ transplant you're a dialysis patient, you're a nursing home resident, those are the things that while we're testing for the more common things like flu and other respiratory illnesses, we may also draw blood cultures, which is where we take a sample of blood and then look to see if we can grow any organisms. And Candida auris is one of those organisms that can grow out of those blood cultures, and will then quickly allow the clinicians to identify the type of organism that's causing the symptoms that are present.
Dr. Vyas, is this a situation where once a patient has this, is diagnosed with this, that they have to isolate?
So it depends on the hospital protocols. Some hospitals have gone to creating some levels of protection, meaning that the healthcare workers are going to be required to wear gloves and gowns before they walk into the room and to administer care. Most of that is to make sure that there isn't patient-to-patient transmission. And then the other one is oftentimes visitors who are coming into the room will still may be asked to wear gloves or even wear a gown itself. Because, as I mentioned, this is really done based on a contact, and this is not a respiratory organism. We're not worried about spread through aerosol or any types of drops. And so there typically are not, in most hospitals, will not be any restrictions on the visitors coming in to see those patients, but oftentimes they'll be asked to wear some additional protection, both for the patient and for the environment, and also for the visitor themselves.
You know, doctor, you might have already mentioned it, but I know we're throwing a lot of information at our viewers, and right on the screen it says cases of a deadly fungus, so I think people's ears are perked up. But talk again about treatment options. How effective are they? You know, how long could someone be suffering with this before they get better?
So oftentimes, common things being common, we oftentimes think mostly for viral infections for people who develop kind of signs and symptoms of illness. Sometimes we think then about bacterial infections, and so those are things that we'll also test for someone who has like strep throat or any other more serious bacterial infection. Fungal infections are still relatively rare, but the challenge is that once they're, so the diagnosis is oftentimes delayed. They're delayed for for a couple reasons. One is physicians have to think about it, and then secondly, our diagnostics tools in 2025 for recognizing these infections are good, but they really could be better. You think about if flu tests, or you think about other viral infections, you can go to the neighborhood store, do a swab, and then determine whether you have these types of infections, much like pregnancy tests. Those tests don't exist for many of our bacterial infections, and really none exist for any of our fungal infections. And so those lack of those tools do inhibit that. When we talk about treatment, there's very few drugs that we have that work. And the drug development in this space has actually been quite slow, and there's a confluence of events that really don't stimulate kind of growth in this particular area by our biotechnology industry in this country. And so really having some additional financial incentives that are built in through government policy is really the best way to ensure that we can have more drugs to be able to start to treat these types of infections.
Doctor, I want to ask you, do you know where this was first spotted recently, that we're even in this position of talking about this in our state? Did it start here? Did it show up somewhere else and then it spread to Illinois?
Yeah, that's a good question. As far as we can tell, and the way this is done is oftentimes researchers will look at the genetic code of various isolates of Candida auris, and they'll try to track to determine which ones are coming, whether they are all coming from the same source or whether they came from different areas. And the reason we call it Candida auris, in one of the cartoons that you just showed had a picture of an ear. The original description of Candida auris came from a Japanese patient in Japan who had an ear infection, and when it was first identified and diagnosed, it was called Candida auris because of that index patient. It turns out through analysis of genetics, we now know that Candida auris, while it was isolated in that patient in Japan, there were actually other cases going on at the same time. So we actually believe that this organism has emerged to become a clinically significant disease simultaneously around the world. So there isn't a single point of origin, but actually is cropped up in a variety of different spaces. Air travel and a variety of other things that allow for a lot of human mobility has really allowed for this disease to move from one country and one continent to another. And so right now there's multiple cases in multiple states in the United States. And as I mentioned earlier, as we start to get better at detecting this, those numbers will continue to rise because we see that. But we also recognize that we're doing our very best to try to mitigate the spread of this organism within our healthcare facilities.
Doctor, I'm not asking you to get political with this question, but I do want to ask you something. I remember last month we were reporting on how several employees on the federal level with the CDC, who obviously does a lot of research with infectious diseases, et cetera, were terminated. Do you think that that will have a hindrance on how we as a country can respond to the rise of different infectious diseases that pop up?
So I do think that, in contrast to many other areas of medicine, I'll speak for myself that, when I first started training, during my formal part of my training, no one taught me anything about Zika virus. No one taught me anything about Ebola. No one taught me anything about Candida auris. Because these things emerge over periods of time. And just in my own short career, I've recognized that organisms have grown in medical importance over a couple years. And because of the changing landscape that we have, having a robust public health system that's not only at the federal level but also at the local level and the state level is exceedingly important for us to be able to recognize when there are potential threats that do come around, and then for us to be able to be responsible and report this to the public, not to create an alarmist situation, but really to make sure that those of us who are focused on these types of organisms are really understanding what's going on, and then engage with our partners, both in the political area as well as in communications, to ensure that the public is well informed about these potential risks.
Well, that's the kind of the question I was going to ask, and maybe you won't like this question because it puts a little bit more pressure on you, but after COVID, everyone's worried, and seeing a headline like this, how concerned should we be? 1 being not concerned at all, to 100 being really concerned. What level were we at with this?
Yeah, so we're not at 100. What we are is we're at, for those patients who are oftentimes accessing our medical care facilities in an intensive way, those who are immunologically fragile. So let me back up. When I say using intensive, I'm oftentimes talking about our hemodialysis patients who oftentimes access our facilities 3 to 4 times a week. Patients whose immune systems are not great, oftentimes either because of autoimmune diseases or because of the medications that we give to suppress the immune system. Those individuals should just have a little bit of a heightened concern that this is there, but it shouldn't necessarily change their practice. It's not that they shouldn't, if they want to go out to the mall to buy Christmas toys, they should certainly go out and do that, and Candida auris shouldn't stop them from doing that. But at the same time, they should just be cognizant of doing the same things that we've always asked people to do, which is really to wash your hands and to practice good hygiene. And those are the things that'll go a long way. Just having an increased sense of those things I think are really important for us to do. If it were to change and be significant, which I don't anticipate it does, but it is going to cause problems in a certain segment of our population, we want those people to be at least informed about those risks.
Dr. Jatin Vyas, fungal expert, you have been absolutely wonderful, thorough in all of your explanations. We really appreciate you joining our show this morning.
Pleasure to be here. Thank you for asking.
All right.
Thank you.
Hopefully we'll see you next time on a positive note. Maybe
Yes.
there's something positive that could come out of this. Thank you so much for your time.